Good morning and welcome, everyone. We're just going to give a few minutes to allow people to get into the room and then we'll get started.
Thank you so much for coming together. It has been an absolute labor of love to put together this conversation and this intentional way of being part of New Jersey Maternal Health Awareness. We are convening human lactation and the legislative body, a journey to equity. And we hope that today can be a plurality of voices. And wherever you are here, whether you are a legislative aide, a parent, an activist, a student, a scholar, or an elected official in New Jersey, you are welcome. My name is Jill Wadnick, and I'm a childbirth educator at Montclair State University, and it is my joy and delight to convene this conversation with so many cherished colleagues together. We'll say that the speakers in this webinar, we recognize that not all people that feed human milk to their children identify as mothers, female, or women, or you might even be an adopted parent. We strive to use inclusive language, but we also recognize that existing reports, research, and laws are cited. We will use the terms in those original documents, and we strive to be inclusive. So in the spirit of acknowledging the urgency of now, this conversation is convened because for even the 95% of women who are able to produce milk, breastfeeding may not always be accessible due to a variety of structural and environmental barriers, including pervasive marketing of infant formula, a lack of clinical support, disruptive maternity care practices, and insufficient workplace and child care practices. Laws and policies at the federal, state, tribal, and local level can help reduce barriers for parents that do want to breastfeed. We know that this conversation in New Jersey is also happening nationally. Within the last decade, overall breastfeeding rates have increased in the United States. However, when the data is disaggregated among these achievements, it's not equitably shared. There's persistent disparities among breastfeeding duration among race, ethnicity, and socioeconomic status. Maternal and pediatric care is not centralized. Family units receive direct and indirect support in so many different settings across the first 1,000 days. Ensuring comprehensive lactation support during this period will require intentional coordination. And this is why we're here. This is why we are gathered together as part of New Jersey Maternal Health Awareness for the intentional coordination of focus on New Jersey-specific resources, toolkits, reports, infographics, and a lot of links will be sent out afterwards. Here is just a couple of samples. With that, from acknowledging that New Jersey has breastfeeding rights and breastfeeding champions at all domains of government policy and systems, it is absolutely my honor to introduce Assemblywoman Brittany Timberlake, Lucky for me, I live in the 34th legislative district. Since 2018, Assemblywoman Brittany Timberlake has been sworn in to represent the cities of Clifton, East Orange, Montclair. I have seen her firsthand advocate not only for maternal infant quality, but also housing stability, economic resources, elevation of community care. And I am so honored to always hear her tell her own story of mothering and governing. Assemblywoman Timberlake, I'm going to stop sharing my screen and welcome you to unmute and be part of our gathering today. Thank you for your time.
Well, thank you so much, Jill, and thank you to everyone who put this forum together. It's a very important conversation, and I'm so excited and honored that you thought of me to be a participant for sure. I was sworn into office in the Assembly in 2018. Prior to that, I was the freeholder president for Essex County. Now they're called county commissioners. And I was sworn into the Assembly 9 months pregnant, and had to hit the ground running because I have a sense of duty, of course, to the constituents who are expecting a lot from me and changes in laws and different things, but also needing to be cognizant, of course, of my maternal duties and the baby bonding. Breastfeeding is something that was pressed upon me even by my mother. I am a breastfed baby. And she breastfed me for about a year, and also my brother. And it was something that I heard mentioned around, the house every once in a while. Well, I breastfed my children. I put that into the back of my mind, I suppose, which then came to the forefront whenever it was time for me to birth my own babies. I'm a big believer in holistic and as close to nature as possible. Of course, I do also support Western medicine. Let's use wisdom here, right? And not everything can be only, holistic care. But if we can do things with the body as natural as possible, particularly as it relates to birth and also the feeding of our babies, then the healthier the female body will be, as will the child. And just doing a lot of research and background on that, I was pretty committed to nursing. So I birthed in a natural birthing process, but in a hospital. And and it's a fantastic facility. It's a mommy baby friendly facility. It's at Morristown Hospital. And they also encourage breastfeeding there. They have certain practices where they do not they won't give you a pacifier right away for the child. They're encouraging the latching on of the child. A lactation consultant will come around and talk with you about the process, because it's not easy and it is a lot of hard work. But I chose to be committed to nursing because I wanted to make sure that after reading, of course, that I was giving them giving my babies the best vitamins for their brains, helping them, in the future with their IQ, in the future with their nutrition, and also their immunities. And a lot of these things we see having come to the forefront, particularly with the COVID-19 crisis. So now that was my first baby, baby Dimitri, in 2018. And in 2021, I gave birth again to baby Damascus. And I was able to nurse Dimitri for 2 years. And now I just finished 1 year down for nursing Damascus. And I'm hoping to continue until I feel as though it's time or I'm ready, or the baby is ready. And whatever that time frame is for any woman, it is your personal choice. No judgment here at all. The healthiest baby is a fed baby, period. And if you can't breastfeed for a number of reasons, that's okay. I always make sure to say that, because I do not want people to feel as though we're being judgy because we're talking about breastfeeding. It is a lot of hard work. I will share with you that I have friends who were not able to go far past the time on maternity because their workplace was not set up to enable them to pump. First of all, just being transparent, I really don't like pumping, but did find a fantastic pump these days where it's wireless and ductless, and I really enjoy it. So we'll enjoy it as much as I can enjoy pumping. It has not made me want to stop pumping. Whereas with my first child, I was done pumping after about 6 months and was just pretty committed to nursing him every time I was in his presence. But so many friends do not have a privacy on their jobs to be able to pump and continue to work while also bringing milk to the baby, and the understanding that it comes along with that. I do believe that a major issue in our country as a whole is the sexualization of breastfeeding, because that's whenever you see the employers get just a little, what do you mean, a lactation room? And they just get a little nervous. And also the debate about whether or not women should be covered in public when nursing versus not. And I have to tell you, covering the baby certainly does work for the first few months, but as soon as that baby learns to grab and to pull and learns that, that he or she can help themselves with not wanting to be covered or being hot, covering isn't always practical. My son right now, trying to cover him at the age of 1, starting probably from the age of, I would say, 6 months or so, he's not into the cover. And everyone around me and everyone in public just kind of has to deal with it. That's the way I look at it, because the baby needs to be fed. And would you want to eat with a blanket over your head? That's what we're asking infants to do. So I think there needs to be a lot of education around what breastfeeding is. This is actually the actual intent of our breast. Sexualizing our breast is not the first intent of what they're to be used for. We are mammals, and the intent of a female body being able to lactate is simply to feed, not for anyone's pleasure per se. So I just think there's a little bit of rewiring of our minds that also has to happen. And I do see that the cultural norms are changing. There are some bills that I have centering lactation. One in specific requires that every woman who births, no matter where the facility is, be visited by a lactation consultant, and that it be something that either is covered by the hospital and however they're doing their billing and their system, or also by the insurance of the woman. I also have a bill that requires any medical provider who is licensed to help to deliver the baby, that they have to let a woman know all of her birthing options that are available in the state of New Jersey. There's more to birthing than just epidural, Pitocin, C-section. There's so much more to it, and I want to make sure that women have the opportunity to choose their birthing plans as their body is healthy enough for them to do that. And there's also one where I believe, and there's been women who have come before me who have done such a phenomenal job making sure that there are lactation rooms that have to be available. I believe it says up to 1 year in the workplace. But I think that we need to take out the time limit, because that also puts a stigma on it. As shared, I've nursed my babies for 2 years. I would have gone longer. I was ready to stop. And like I said, that's a personal decision that every woman should be able to decide for her and her baby, and not feel the pressure of, okay, I need to stop before the year is up, because when I get to work, I'm not going to be able to pump and do the necessary things that I need to do in private. I would like to see a workplace in a perfect world where every facility just happens to have a lactation room, the way that we happen to have bathrooms and facilities like that. There should always be a section available for a mom to go in to do what she needs to do. And if not, until society is ready to get to that level, then certainly in public places, people just need to be ready to understand that a breast is a breast, And sometimes you see breast whenever you have to feed your child, and people have to deal with that and not sexualize it, and understand that it is really one of the best building blocks that you can do early on for your child. And particularly, it's important to mention that in certain cultures, breastfeeding is not as prominent as it is in others. And it's important for African American women to know that breastfeeding is so much easier than formula, only because, well, first of all, there's also the financial benefit, right? How much money have my family and I saved that we did not have to spend on formula? But just the benefits of the mind development, of the nutritional development. And again, as I started to speak about, but I didn't finish, and then I will conclude, is with the COVID-19 pandemic, being able to pass those antibodies on to the baby. I told you before, I'm a holistic kind of person. So I took my time to get the vaccination, only because I was nursing, and everything that I put in my body can throw his little body off kilter. If I eat, in the beginning, he was very sensitive to milk. If I eat milk or anything that's dairy, consume dairy, then I would see an effect on his body. So I needed a little bit more time, because I wanted to make sure, you know how it is to be a mom. Whatever happens to you, as long as that child is okay. And I just wanted to make sure that the child would be okay through the vaccine. And through talking to different healthcare professionals, I took my time and I came to the conclusion that the best decision would be to become vaccinated and to pass the antibodies on to my baby. And what I did was I took that opportunity. I shared on my social media page, nursing the child, my baby, while actually getting the shot. And I continued to then be conscious about pumping, and I would mix the milk with dairy milk and give it to my son, my 3-year-old son, in a cup. So I would nurse the infant right directly from the breast, and then I would also give the antibodies to my 3-year-old in the cup, who was no longer nursing. He was done by the age of 2. But I wanted to be conscious, and I did feel a little like a superwoman, being able to help build their immune system. And that was very important to me, particularly during a time such as this that we're living in, where we don't really know what the next evolution is of this virus. And we really have to undergird ourselves as much as possible with the information that we have at hand. So this is who I am. This is what I do. This is what I believe in. And I'm very grateful for all of your advocacy in this area. And thank you for having me.
Awesome. Thank you so much for sharing your story and your lived experience as Assemblywoman Timberlake. We really appreciate you joining our conversation today. So our next speaker is Dr. Nastasha Davis. She is a registered nurse, international board certified lactation consultant, mother of 4, and a resident of West Orange, New Jersey. She has over 17 years of experience working with birthing and lactating families. Nastasha is passionate about improving access to qualified lactation professionals and improving breastfeeding rates in the Black community. Nastasha founded the Perinatal Health Equity Initiative in 2018, a nonprofit advocacy and support organization dedicated to eliminating racial disparities in Black infant and maternal health. In addition to her public health commitments, Nastasha serves as assistant professor of nursing at Montclair State University. So without further ado.
Thank you. I'm going to just switch views because I see I'm swapped. Are you able to see the presentation? Okay. Thank you. Okay, so I want to thank Assemblywoman Timberlake for her presence and her advocacy. Hearing her story, definitely powerful, especially sharing the vaccination piece, which we know there is a lot of hesitancy, particularly in the Black community. And so I thank you for bringing that to the forefront. I'm starting with this slide, and I do not know where this quote came from, but I remember listening to a presentation, and it really stood out to me about breastfeeding, chest feeding being more than just a feeding choice and a healthcare behavior. And we as an organization have really shifted towards looking at the public health component of human milk. So we know a couple of things about human milk, and this is a very short summary, but it is the optimal feeding choice for most infants, promotes the development of immune system, which is vital during this season of COVID, and meets all the nutritional needs of a full-term infant. So no additional foods are needed. In the significance, this is again, very short summary. And because our work is really centered on the Black breastfeeding experience, what you're going to hear from me is going to be centered on that. And these are the benefits to all mothers and people who are providing human milk. But I'm highlighting this in specific to Black women, as these are some of the common causes of maternal mortality and morbidity. And so early initiation of breastfeeding really can help change the course of health. And we talk a lot about the benefit of human milk to the infant, and it's less discussed about what the benefit is to the mother or the birthing person. It is a dynamic relationship that is shared among the two of them. And I think it's important to mention. There's a new study that came out about cardiovascular health and the relationship between that and human lactation. And if we look at our state's common causes of maternal death, cardiovascular disease is up there. And so this is another way that we can help prevent maternal mortality. Want to just highlight the different ways in which people will choose to feed their babies. There is no one right way to provide human milk. There are those who will exclusively breastfeed directly from the tap, those who will exclusively pump, which is a viable and acceptable option. Some who will do a combination of breast and formula. And then chest feeding for those who identify with that terminology, and then any combination of the above. And so however people choose is the right way for them. Do want to just highlight the longevity, and Assemblywoman Timberlake did a great job with discussing that. There is no end date to when someone chooses to stop breastfeeding. That is a personal decision, but we do have recommendations. The World Health Organization speaks to exclusivity for the first 6 months, and then moving on to at least the first 2 years of life. In most countries, the age of weaning is somewhere between 2 and 3. Okay, not as common in the United States, but around the globe, that is the common age of weaning. And then the American Academy of Pediatrics encourage it for at least a year or longer. And the benefits that I discussed really come from exclusivity. And that's really, really important because there is a dose-dependent relationship with human lactation. So the longer that someone continues to provide human milk to their baby, the more benefits that they and their baby receive. And we know that's especially true with premenopausal breast cancer, for example. The longer that someone breastfeeds over the course of their lifetime gives them much more protection. Now, when we talk about who provides lactation care, as an IBCLC, and we have a few on the call, myself and Ellen, we are the higher ranking lactation credential, meaning that there is a different level of education and training that's received by an IBCLC. Each one of these providers on the pyramid have their role. IBCLCs are more clinically based, so moving into complications that you might see with like preterm infants and things like that, but run the whole gamut of lactation support. Certified lactation consultants, CBS, and certified lactation educators. These are independently run credentials that require at least somewhere between 45 and 50 hours of education, and it's all didactic education, so no clinical. IBCLCs can have upward of 1,000 hours of clinical time, and so very different scope of practice. And peer counselors are those who have experience breastfeeding themselves, and so then work into a peer capacity of supporting others in their role of human lactation. And it's a very critical role because its success has been linked to having that social support and peer support. And I highlight this because often when we talk about human lactation, we talk less about IBCLCs and their role, and the referrals are typically made to nurses and to physicians. And the IBCLC has a different skill set and a different set of training. And I can speak on the nursing end. We don't receive a ton of lactation education in school. It's not our primary focus. And so it is up to us as we go into practice to acquire that additional education. So I do want to just differentiate that there's nothing about a nurse that makes them an expert in lactation care. By that designation alone, it is really pursuing the additional education that is of the value there. But in saying that, we know that there is a relation to the conversations that families have with their providers. So when a physician discusses the benefits of human milk, and when a nurse discusses the benefits of human milk, there's a likelihood of up to 4 times that that person is then going to breastfeed. And so those conversations are crucial. This is just some data that really just shows the disparity in human lactation. If we were to do a comparison group, Hispanic and Latinx population actually has one of the highest breastfeeding initiation rates. We tend to compare often Black-white, but really we should be comparing to groups that are successful, and the Hispanic and Asian groups actually tend to be more successful in their lactation journeys. And so looking at that, there's an error on this slide. I'm pointing this out, this slide here, about our infant mortality rate briefly. It is high in New Jersey, and I think most of us who have been doing this work know that, but we don't talk as much about the benefits of human milk in its relation here. These are some of the cities in New Jersey that have the highest Black infant mortality rates. And these are some of the top causes. And where I believe breastfeeding and human lactation has a role is in SIDS prevention and preterm and low birth weight. We know that the way human milk is delivered has the ability to impact these rates. This is a quick slide of baby-friendly hospitals in New Jersey. The 2 that I highlighted are the 2 that are in communities of color. You will see that most of the hospitals that we have designated are not in communities of color, and that is not helpful to us. But also do want to highlight that as we're moving through increasing our number of hospitals that are baby friendly, that new legislation regarding implicit bias and anti-racism training is going to be important, because there is data showing that even having a baby-friendly designation is not protective specifically for Black women. So we still have a lot of work to do with working on our implicit bias and racism. This is some of the systemic barriers that are common to the Black breastfeeding experience. So if you deliver in a hospital that is in a Black community, you are 9 times more likely to have been offered formula during that stay. Infants are often formula fed without consent or knowledge by the birthing parent. WIC, although offers many breastfeeding services, we know that WIC participants have lower breastfeeding rates in general. We have very little conversations with our providers about the benefits of human lactation. It's often actually assumed that Black patients are not going to breastfeed, and there's actually an entire article labeled "Why Bother? They're not going to do it anyway," which goes into detail about how that conversation often gets missed. And imagery, representation. I can't shout enough how important it is to have visible images of Black women breastfeeding, which we don't see as often. Other benefits, lack of practical breastfeeding knowledge. Knowing about the benefits of human milk is wonderful, but we can't apply those to problems. So when we're having a difficult time latching the baby, or we're having a cluster feeding session that we don't recognize, we need to make sure that patients are being provided with information that is going to be useful in helping them initiate and maintain lactation. Mentorship is an issue. We, again, tout the importance of our peer support groups, but there aren't a ton in our state. And then our high preterm birth weight. Black mothers are more likely to deliver a high risk pregnancy and have a preterm birth. And so we don't have a lot of support in our NICUs for Black mothers that are nursing. I do want to just highlight briefly 2 organizations in our state. One is my own, so full transparency, Sisters Who Breastfeed is our organization. Chocolate Milk Cafe is run by Takesha Miller, who is a good friend of mine. these organizations are important as that they provide breastfeeding support specifically to Black women. They are closed groups really to work on the unique needs of Black women. I established the first group in New Jersey in 2016, and there have since been more that have come along. But these spaces are really important and need support. And I'm highlighting that these things come from New Jersey because in New Jersey, the work that we do tends to come from outside of New Jersey very frequently. And there are amazing people doing amazing work within our state, and that work needs to be elevated and highlighted as well. I will say also, when it comes to diversity in care, nationally, less than 4% of all IBCLCs are Black. In New Jersey, there are 0 IBCLC programs. So if someone wanted to become an IBCLC, New Jersey offers no pathway for that to happen. And there's a lot of barriers in becoming one. It's easier when you're a nurse, but being a nurse does not make you a good IBCLC. And so we need to provide other avenues for entry into practice. There's also a lot of data on culturally congruent care and how when families are receiving care by providers that look like them, their outcomes are better. Few highlights on local research. This is a research study that I did back in 2019 that looked at barriers to exclusive breastfeeding in Black women. These were the 3 themes that emerged. Health providers, so really looking at nurses, physician, OBs, and IBCLCs were actually the common causes of why Black women were unable to be exclusive. So all people who are designed to protect Black support breastfeeding did not do so frequently enough when it came to Black women. Not being educated, and then again, the role of implicit bias and racism and just not having adequate access to support. And then these are just is a quick snapshot of how COVID really impacted breastfeeding. So while we are seeing an increase, I think when this data comes out, we're going to see a little bit of a drop in our initiation rates because of what happened during COVID. So there was not a lot of access to lactation support. WIC had closed down in many locations. We were hearing bad advice being given out frequently by people who were just not educated on lactation. Formula was already being introduced pretty early, but it was significantly earlier during COVID. IBCLC staff was pulled to other areas of the unit. In New Jersey, we have no guidelines on staffing ratios for the number of IBCLCs, so they are often disproportionate. One IBCLC to a unit with 30 or more beds is not adequate access to lactation support. And then just giving a summary of what's going on in the lactation world of how you can stay abreast. Black Breastfeeding Week was established by these lovely women here on the slide. It is celebrated August 25th and 31st through the 31st. Every time we host an event, there's always a question of why we need a Black Breastfeeding Week. This is a snapshot of why, and really just elevating the importance of equity over equality. When we are working in equity, we're providing resources to those that are most in need. And right now, Black breastfeeding is suffering the most. And so we are allocating our resources to that. Black Maternal Health Week, which was established by the Black Mamas Matter Alliance, will be coming up shortly in April 11th through the 17th. And then just some research that we are working on. We were funded by the Burke Foundation to do a landscape analysis of Black breastfeeding in the state. And so we hope to have really good feedback from the community, policy recommendations, funding roadmaps, and really elevating the voices of Black women in the community. And I'm going to stop there and hand it back to Sakaya.
Thank you, Natasha. That was awesome. Thank you so much for that overview of human lactation, specifically in New Jersey. So thank you so much, Dr. Davis. So next, we're going to take a look at breastfeeding rates and trends in New Jersey, as well as New Jersey's laws to protect and support lactation with Ellen Mon, who is an international board certified lactation consultant, a trustee at the New Jersey Breastfeeding Coalition, and an adjunct professor in the Drexel University Human Lactation Certificate Program.
Thank you so much, Zakaya, for that great introduction. And let me get to slides. There we go. And it is a privilege to be with you all today. I know many breastfeeding advocates are here. And thank you again, Assemblywoman Timberlake, for your great advocacy with regard to some of the laws that I'm about to speak about. But in any case, let's just start taking a quick look at breastfeeding in New Jersey. And here we have a graph about showing ever breastfed. These are initiation rates. We have two primary sources of data in New Jersey, the New Jersey State Health Assessment Data Online database known as New Jersey SHAD. That's maintained by the New Jersey Department of Health, and the US Centers for Disease Control and Prevention National Immunization Survey data. So I'll be using both of those today. On SHAD, there's also two types of lactation data. There's the PRAMS survey data, that's from the Pregnancy Risk Assessment Monitoring System, and that's a nationwide survey that New Jersey participates in. And then we also have the birth certificate data in New Jersey, and that's a wealth of information as well about what's happening in the hospitals. And what this graph shows, and I say at the outset, I'm not a data person or a graph designer by training. So you're going to see my graphs have different legends here. But what this shows is that there's a little bit of a difference between the data, but that in any case, breastfeeding initiation, meaning ever breastfed, ever received any breast milk or given any breast milk, those rates are quite high in New Jersey. They're somewhere between 80 and 90%. So this shows, just not what happens in the hospital, but what can happen after discharge from the hospital as well. So we know that there's a lot of attempts to breastfeed. However, some of them may be small, and this number would include even those attempts where there were just a few servings of breast milk given to an infant, possibly even express breast milk, as well as exclusive breastfeeding. So we're doing a pretty good job getting started in New Jersey. Let's take a deeper dive into what's happening in the hospital. So this is data from the birth certificates, and this shows feeding method at discharge. And I just took the last 5 years. I know that the 2020 data is preliminary, but I've included that as well, and appreciate the work. Whoops, sorry about that. The work that is being done to collect this data. But it shows here that the data from the birth certificates in blue and I'm sorry, I'm going to move my screen and legend here so I can see there we go. The combination feeding is in blue at the top, and historically that has been the highest, and it sort of peaked in 2018 and has dipped a bit. Below that is breastfeeding in brown, and breastfeeding has been, relatively stable within a few percentage points. Formula feeding is in gray. And what we're seeing is that's actually, for the first time in many years, starting to tick upward. And then the yellow line is unknown, just unreported. So we can see that combination feeding is going down, and the combination feeding is breast in any formula. Formula feeding is going up, and exclusive breastfeeding is sort of staying, stable, but not going up for sure. This is a historic table that was put together by the Department of Health. Just wanted to go back for a minute to 2000, the year 2000, so you could see what's going on. And this is breastfeeding exclusively or in combination with formula shown by race. And as we can see, the graph provides this interesting longer-term view of hospital-based breastfeeding, and that we can see across all races that something happened in 2010, which caused the previous increases in breastfeeding to slow down. And we can see that the largest impact is occurring in Asian parents. But racial and ethnic disparities in breastfeeding rates continued throughout through the whole 20-year period. And we're concerned about these differences because, as Dr. Davis said, there are significant differences in health outcomes, maternal and infant mortality rates, and rates of chronic disease in New Jersey, and those diseases such as cancer, cardiovascular disease, and diabetes. And these differences exist by race and ethnicity in this country and in this state. And supporting breastfeeding needs to be a health imperative to ensure optimal health for families and to address health equity in this state. So breaking down a little further, let's zero in on that 5-year period between 2016 and 2020 and take a closer look at the differences in rates. So I apologize that the line colors have changed because I've been using different graphing methods. But what this graph helps us to see more clearly is that there's a change that's been happening in the last couple of years. We can see for the first time since 2000 that Asians, shown in the yellow line, are no longer initiating breastfeeding in the hospital at the highest rates as had been historically. And while any breastfeeding in the hospital stayed pretty stable during that period for Black, white, and Hispanic mothers until 2019, Black, Hispanic, and Asian breastfeeding decreased between 2019 and 2020. And white breastfeeding, shown by the blue line, increased. So now we know, as Dr. Davis mentioned, we know that there can be aberrations in this data given practices that happened in the hospital during COVID. And we know that in certain places, babies were separated from COVID positive mothers, that babies and mothers were discharged within 24 hours, which of course limited their access to lactation care in the hospital and in birthing centers. And so many things could be happening here. But it certainly makes us question from an equity standpoint, what happened in the hospitals in 2020, when we might have expected breastfeeding to decrease across all races. And while the differences are not huge, they still remain significant. As Dr. Davis also mentioned, those recommendations of the American Academy of Pediatrics and the World Health Organization for length of breastfeeding, and that recommendation that babies should be breastfed exclusively or fed human milk exclusively through the first 6 months with the introduction of solid foods thereafter. So what this shows us is, we can see here is that despite our, as we discussed earlier, our very high initiation rates and those ever breastfeeding rates that we saw, that breastfeeding, especially exclusive breastfeeding, drops precipitously from those early days through the first 3 months. By 2018, only a little more than a third of all infants were exclusively breastfeeding in that year, and that rate has been decreasing since 2015. And we can also see that less than a quarter of all infants are exclusively breastfed at 6 months. Now, the CDC data, the last data, the year for full data is 2018. I don't have more recent than that. Also, that any breastfeeding at 6 months is just around 60%. So this is something to be concerned about. While we have high initiation rates that we are dropping, our rates drop off very quickly after discharge from the hospital. Now, just switching gears to talk about what we have at our disposal legally in New Jersey and policy-wise, we should start with our New Jersey Public Breastfeeding Law. It was the first law on our books. It's been enacted since 1997. However, it's important to really, we think in this day and age, everyone should know that it's okay to breastfeed in public and that we shouldn't need a law for that. But we do need a law, and we are aware that there's still a lack of awareness in many circles about how, that breastfeeding in public is legal. Here's our law. There are penalties for violation of the law. We have breastfeeding rights information on the New Jersey Breastfeeding Coalition website. But what many people misunderstand is the reach of the law, that a place of public accommodation, as the law says, that a mother can breastfeed her baby in any location of a place of public accommodation, is quite broad. It reaches to wherever people are invited to be. There's very few locations that will not be considered a place of public accommodation. It includes businesses, schools, restaurants, government offices, medical offices. New Jersey, fortunately, also has very strong workplace protections. Breastfeeding was added to the list of protected statuses in the New Jersey law against discrimination. And so what our law requires is that employers must provide reasonable lactation accommodations, including reasonable break time to express milk, a private place to pump other than a toilet stall that's in close proximity to the employee's work area. There's no specific time limit on this accommodation, meaning that a mother can pump for greater than a year if the child is still receiving breast milk. And this law applies to all employers, regardless of number of employees. These state protections that we have in New Jersey are actually stronger than the federal protections. There's also provision that requires that employers may not discriminate against a person in employment on the basis of their breastfeeding status, and can also not really allow any sort of harassment against breastfeeding employees, which sometimes happens from coworkers. So we're privileged to have a very strong law in New Jersey. We also have some New Jersey laws on donor human milk. Donor human milk is so important. As Assemblywoman Timberlake mentioned, sometimes it's hard to get breastfeeding off to a good start and sufficient milk isn't available right away. Sometimes babies or mothers can be sick, which would impact their ability to breastfeed. So in New Jersey, human milk banks must be registered and accredited by the Department of Health. That law was signed in 2018. At this moment, we're still awaiting some enabling regulations and implementation of that law, but it's important that we do get that moving in terms of there being access to coverage, insurance and Medicaid coverage for donor human milk. New Jersey law also requires our state Medicaid program to provide coverage for pasteurized donor human milk under specific circumstances regarding the condition of the baby and the mother, and that would be without copayment or cost sharing. And Medicaid is waiting for those above regulations and guidance to move forward with that. In New Jersey, health insurers are also required to provide coverage for human donor milk under certain circumstances without that copayment or cost sharing. And we find that that coverage varies depending upon the insurance company. Self-insured insurance plans are actually not covered by that law, but for example, the state health benefits plan would be covered and other types of insurance. And we are aware that sometimes the coverage is still difficult to obtain. New Jersey law also requires insurance and Medicaid coverage for lactation services and equipment. And that's required to be provided without any cost sharing, and that's for comprehensive lactation support by a international board certified lactation consultant or lactation counseling by a lactation counselor. That law also requires coverage for the cost of renting or purchasing electric or manual breastfeeding equipment. And thank you again, Assemblywoman Timberlake, for your co-sponsorship for that law. We know that that law is still not fully implemented. Insurance companies are providing a certain amount of insurance coverage. However, we do know that sometimes there are glitches, there are loopholes that are exploited, and sometimes coverage is provided. And I'm hearing from lactation consultants in the community that sometimes insurance companies come back and try to get the money back. So Medicaid has put out guidance on Medicaid coverage for breastfeeding equipment and pumps, and is working on this the guidance for providing lactation or Medicaid coverage for lactation support, and that would be subject also to federal approval by federal Medicaid. Just another enacted lactation-related law. There's a three-pronged law that requires certain public facilities and offices to provide an on-site lactation room. The New Jersey Department of Health is required to provide information about lactation room availability. And the Department of Education is required to provide information annually on lactation policies in New Jersey schools, colleges, and universities. And we know that some of the facets of this are still in progress. That was enacted in 2019, but some of that law is still being worked upon. And there is a need for an amendment of that law to actually include in that third part, the Board of Higher Education, because the Department of Education actually doesn't cover or report on lactation policies in our universities and colleges. So we hope to make progress with that this year and getting that law amended so that we can have full access to information about lactation policies in schools, colleges, and universities. Because we are so concerned, and this webinar is centered and focused on lactation equity, racial and ethnic disparities in breastfeeding support are so important for us to be monitoring and to be addressing. There is a law in effect that requires the Child Fatality and Near Fatality Review Board to review the extent to which racial and ethnic disparities in breastfeeding initiation and duration indicate the need to increase breastfeeding supports among racial and ethnic populations throughout the state. Haven't been able to find if that report has come out yet, and been awaiting a response to find out more information about that and where that stands. New Jersey also restricts isolated confinement in correctional facilities based on several factors, including pregnancy and breastfeeding status. And I'm sure our Department of Corrections hopefully is working on that. And quite significantly, the hospital regulations were amended in 2014 and amended again in 2018 to require more breastfeeding-friendly practices in New Jersey hospitals. Our next speaker is going to talk a little bit more about the hospital experience, so I will leave that to her. And just conclude by saying that strategic planning is sorely needed for coordinated lactation policy across all sectors in New Jersey in order to normalize human milk feeding. The New Jersey Breastfeeding Strategic Plan was drafted in 2020 through a partnership with the New Jersey Breastfeeding Coalition, the New Jersey Department of Health, and Central Jersey Family Health Consortium to provide a blueprint of concrete actions for systems, environmental, and policy changes in New Jersey. That plan is currently under review by the Department of Health, but it's so important at this moment for us to move our focus to strategic planning, to work together across all sectors to normalize breastfeeding and chest feeding and human milk feeding. These changes are so important. While we're focused on, we will be focused a little bit more on hospital support today, and we talked a little bit about that in our data. There are so many facets that affect success with human milk feeding, and we need to have a coordinated plan to focus on them all. I thank you for listening, and at this time, it's my honor to introduce the next speaker, a wonderful breastfeeding advocate and clinician, Dr. Rose St. Fleur. Dr. St. Fleur is a pediatrician and pediatric hospitalist at Jersey Shore University Medical Center. She's also an international board certified lactation consultant and the director for the Center of Breastfeeding at Jersey Shore. And last but not least, she's a fellow in both the Academy of Breastfeeding Medicine and the Academy of Pediatrics. And we are very lucky to have Dr. St. Fleur in our state doing the work that she does. Thank you so much. And I hand the mic to Dr. St. Fleur.
Thank you so much, Ellen. That was just a wonderful presentation. I am going to share my screen. And thank you, Anastasia, also. Dr. Davis, that was also a great presentation. And I will piggyback on both of what you guys said. So I'm going to talk about a lot of what we already discussed, really just kind of putting it together, but my lens will be from the hospital perspective because I'm a pediatrician. I'm not just a pediatrician, I'm a hospital-based pediatrician, so I work in hospitals every single day. Jersey Shore University Medical Center is a baby-friendly facility, just like Morristown is. I was instrumental in getting it started. I was part of the core team, the beginning team, and I still continue to be the medical champion for the Jersey Shore for the baby-friendly hospital initiative at Jersey Shore, but also all throughout Hackensack Meridian. And I've seen firsthand how it works and how it doesn't work, as well as how other hospital practices really influence breastfeeding. And so this will be where I'm going to talk about. So I want to really begin with why breastfeeding matters. And we've already discussed this, but just like what Dr. Davis was saying, we talk a lot about the child and the importance of breastfeeding for the child. Of course, as a pediatrician, I immediately wanted to do that as well. But I want to really, really emphasize just how much breastfeeding matters for the mother this time around, because I think a lot of us, including those of us who are listening in, know that there are tremendous benefits for breastfeeding for children, but many of us are not really aware of just how much breastfeeding supports the mother, not just during the time that she breastfeeds, but also for her entire lifespan, her literal entire lifespan. And so, yes, there is a paper that just came out from the Journal of the American Heart Association, so not a lactation journal. The American Heart Association has come forward to really make very strong statements, finally, that breastfeeding really, really does have a protective effect against cardiovascular disease, specifically heart attack and stroke. There is plenty of research, including from cancer organizations, that talk about the importance of breastfeeding for reducing breast cancer risk. And there is plenty of research supporting and including endorsements from the American Dietetic Association talking about the importance of breastfeeding for reduction of risk for diabetes and for evolution of diabetes once you have diabetes. And so, many of us are talking about exercise and eating right and, getting good sleep and all of these things as ways that you can mitigate your lifelong risk for these diseases, but we don't talk enough about how important breastfeeding is. And it's important to recognize too that cardiovascular disease, breast cancer, and diabetes are among the top five causes of death for US women overall. But cardiovascular disease, cancer, and stroke are the top 3 causes of death for Black women overall. So the connection is very obvious. If we really, really want to improve the quality of life throughout the lifespan, reduce risk of morbidity and mortality, make sure that that mom is present for her baby, not just when she breastfeeds, but also when she walks down the aisle, right? We really want to make sure that we endorse and protect breastfeeding. And breastfeeding disparities continue. So it's already been mentioned that African-American women are 3 to 4 times more likely to die from perinatal related deaths compared to white women. African-American infants are 2.4 times more likely to die than white neonates. They are more likely to also be premature. They are more likely to also die from premature related illnesses. And so considering both of these facts, the slide before as well as this slide, I also say that breastfeeding is an important human right as a public health issue, but it's really also a human right. And as a human right, it's very, very much worthy of its legal protection. And breastfeeding equity justice is a form of social justice, just like any other form of social justice that we talk about and we speak about. Breastfeeding equity is right up there because the breastfeeding disparities that exist are very, very much in line to the other perinatal disparities that we see and are also very much in line to the other healthcare disparities that we see even outside of breastfeeding. So it all goes along the same track here. And just like what Ellen Mon was saying, the lactation portion of the New Jersey hospital state regs was introduced in 2014. I apologize, I wrote that it was revised in 17, but it was revised in 2018, and it does call for hospitals to provide support. And that is detailed extensively as to what support means for breastfeeding parents and babies, so breastfeeding families. A patient may elect to file a complaint with the New Jersey DOH if they feel like there isn't adequate support for breastfeeding at their clinical facility. And the scope is quite broad. So we're not just talking about where you birthed your baby, but we're also talking about neonatal ICUs. We're talking about emergency departments, both emergency departments that sit within hospital facilities, as well as emergency departments that are outside of hospital facilities, so standalone units like urgent care centers, trauma bays, and same-day surgeries. And by support, we mean the prenatal setting. So starting from when the patient goes in to receive her first education about pregnancy and how to maintain and support her pregnancy, during delivery, which includes the 10 steps. So that's the skin to skin, the pacifier use, like you were saying, Assemblywoman Timberlake, the rooming in benefits and all of that. After delivery, which includes providing a place for a woman to have lactation specific support. So not just follow up with your pediatrician, but follow up with your pediatrician and follow up with this lactation community support group or lactation consultant or wherever in order to receive lactation specific support. And then finally trained hospital staff. This is a link to a picture of the website of Zip Milk, which is one way that outpatient resources are provided to patients. So a patient can go on this website and she can type in her zip code. And then from there, she may be able to access local lactation consultants or clinics or places where she can receive lactation support. So this is one example of what we mean when we say providing outpatient lactation support. So the regs are extensive. They're very, very well written. They're really, really comprehensive. They talk about any place where a woman happens to be, where she is breastfeeding and calling for support to be implemented right then and there. But there really is very little data about how the NJ regs, the modified regs, have really impacted breastfeeding support. There are no current metrics to really follow what happened and how we have improved or not improved since the regs have come in, aside from the exclusive breastfeeding data that we have presented to us from Ellen. And then this sort of idea of, call us we won't call you. You know, if you've got an issue with how your hospital care was, you may certainly call this website, number, which is listed on this website, or you may file your complaint through this website. Really is probably not enough to get an adequate snapshot of what is really happening within these hospitals. And it also introduces other challenges, like very basic things. What if the patient's primary language is not English? You know, the complaint site is in English. Okay, what if the family doesn't know where or how to file a complaint? You know, we are experts, so we know all about these regs and we know exactly how to access the complaint, and we can send this to a patient, but to someone who may not have that information, they may not be able to share that with their patient. What if the family has no internet access? What if they don't know even whether or not their breastfeeding rights were even violated in the first place? They don't know what they were allowed to have access to. And we hear this all the time. I went to the emergency room because I had a pain in my knee. They gave me an antibiotic. They told me to stop breastfeeding. So I stopped breastfeeding, and that's the end of the story. Well, they didn't know that this is what was not supposed to happen, right? So they might not know. What if a family, what will the family know after a complaint is filed? You know, will somebody call them back, for example? Or what if a family fears retaliation or even worsening disparate care? And this is especially true for immigrant families, for non-English speaking families, for African-American families, Hispanic, Latino, Indigenous families. They may worry that, yeah, they acknowledge that the quality of their care was definitely insufficient or not what they needed, but what will happen if they file a complaint? Does that mean that something will happen back to them? And so the complaint line is a great idea, but it probably is not enough in order for us to really get a very good snapshot about how these state regs are really impacting lactation support. And I call this the great furlough because, again, like I said, I work in a hospital every single day. So I witnessed and saw this with my own eyes. Yes, lactation consultants have and are continuing to get pulled from hospital facilities to do non-lactation based care. It happens all the time. One day you walk in, your LC is next to you. The next day she's gone. She's, you know, helping with the vaccination clinic, or she's on some other unit that I never heard of where there are no pregnant patients, or there might be one, you know, or something like that, you know, but where her skills are not where she's being utilized. And this continues to happen again and again. The lactation staff that remain, we may find that their ability to properly care for the patient is also highly restricted, okay, because the idea is the most essential staff are supposed to be in with the family. And many times lactation staff is just not considered essential enough. Any education or training, much of that has stalled since the pandemic. Hospitals that were looking to possibly become baby friendly changed their minds and decided they didn't want to do that because now we have to focus on COVID. Face breastfeeding support groups have largely disbanded. There's really not very many around, certainly not in my area. I'm just talking about where I am in Neptune. There are no known face-to-face breastfeeding support groups that exist anymore. There's a number of them that exist online, but again, we have the challenges of internet access and English speaking capacities, you know, all of these other challenges which continue to make it difficult for parents to find support. And then online support, like say, for example, our Center for Breastfeeding will offer online Zoom support and education, may not be enough for many families. You know, it's really hard to provide good lactation support over the phone or even online where you can visualize a woman breastfeeding or nursing her patient. And then you may have language barriers. So we can overcome our language barriers because we have the services in place. Many hospital facilities just don't simply have the services in place, and other facilities that don't have the resources as a larger hospital system, which certainly doesn't have the services in place. And so the bigger picture really does show this kind of desert-like landscape where you have a mother who makes the choice to breastfeed her baby, but she really cannot find anybody who can really help her get the answers that she needs to get her started and to get her going and to keep her going. So let's talk about WIC. It's already been mentioned. WIC is absolutely a substantial resource for families that choose to breastfeed. This is a reminder of what WIC does for our families. a lot is the short answer to it. It educates patients on breastfeeding. It gives them education, counseling, and support. It provides peer counselors for them to talk to. It provides equipment, so access to breast pumps and breast parts. And this is especially critical for families for whom the ACA does not cover. And so if you have a patient that is not insurance eligible, uninsured patients who are frequently our transient families, migrant families, immigrant families, they may not be eligible for insurance in the state of New Jersey. They may choose not to apply for insurance in New Jersey because of fear of being deported. They will not have access to a breast pump through insurance. And so they rely heavily on WIC services in order for this to happen. Breastfeeding WIC families also get an enhanced food package. So it's not really just about the baby and access to breastfeeding for the baby, but also for the mother. And so this is critically important for many families. But what we're finding is that WIC participation is not enrolling at the same rate as other subsidies are. And so looking at the study that was done on the Center for Budget and Policy Priorities, there was an uptick for SNAP participation as well as for Medicaid enrollment, which makes sense because with the pandemic, many people lost their jobs. Many people were not able to support themselves. And so they found themselves in a financial level where they were eligible for such subsidies, but WIC participation did not keep up. So in this table, you can see since February 2020 to February 2021, you can see that even though SNAP eligibility went up, Medicaid eligibility went up, WIC participation actually went down. And you really can see this in the community with families that are suddenly now saying that they're struggling to find enough money to even buy for basic things, formula, for example. You know, two issues. One, sometimes formula is not even available in the storefronts because we're having lots of things that are not available, lots of things that are not being shipped in at the same rate. Two, they may have known that they were not able to afford formula. They may have attempted to breastfeed and didn't find the support that they needed in order to continue breastfeeding. So breastfeeding support falls into this gap when WIC is not as available as they were because of the pandemic. And then WIC participation is also going down. So again, that widens the gap. And then the families that struggle the most are Black and Latino families, vulnerable populations, low income populations, because these of course are the populations that oftentimes will be most eligible and most likely to receive WIC. The Baby Friendly Hospital Initiative is something that I'm very heavily involved in. Like I said, I was the champion and still continue to be for Baby Friendly for Jersey Shore, and I helped other hospitals become Baby Friendly, and I speak about Baby Friendly, and I've worked extensively with Baby Friendly. It is an initiative that is a resource and a tool and is oftentimes the go-to place for hospitals to improve their breastfeeding. So a hospital system may say, our breastfeeding isn't working. We're not enough of our patients are breastfeeding. What do we do? Oh, here, let's become baby friendly. And there is very good evidence that shows that baby friendly can really make a huge difference. And just to backtrack just one step a little bit, not assuming that everybody here knows exactly what baby friendly is, but what it is it's an international certification that you can acquire if you agree to follow and adhere to a certain number of evidence-based steps that has been shown to improve and increase initiation for breastfeeding and maintenance of breastfeeding in the hospital, under the pretense that if you get the mom off on the right foot, you start her on the right foot, she will continue to breastfeed for some time after discharge. Of course, there is a huge drop off, like we all know, but sustenance within the hospital is better than not starting at all, of course. Okay, so the New Jersey hospital state regs are drafted to mimic these 10 steps, and just over a quarter of hospitals nationally are baby friendly, including 14 hospitals that are within the state of New Jersey alone. Baby Friendly continues to be an initiative that has its challenges. And so one is that it's costly. It's not hugely expensive, but it certainly costs money. And this oftentimes is a sufficient enough barrier for facilities to choose not to become baby friendly. there is research that shows that while baby friendly is good with initiating breastfeeding, and this is no small feat. I mean, there was a research study that just came out a couple of weeks ago that shows that just the initiation of breastfeeding carries significant changes in mortality for families across all racial backgrounds. So white families, Black families, and Latino families. So initiation is very important, but sustaining breastfeeding even throughout the hospital stay continues to be a challenge throughout the nation for women of color. And so when we see that baby friendly can help with initiating breastfeeding, we do see that baby friendly still struggles to keep these mothers breastfeeding even at the point of discharge. So there's already a drop off even at the point of discharge, and then of course an even steeper drop off after discharge. And just like what Dr. Davis was saying, areas with more Black people are more likely to score lower on MPEAK score practice metrics compared to areas with fewer Black persons. So I didn't talk too much about MPEAK here for sake of time, but MPEAK is the Maternity Practices in Infant Nutrition and Care, which is essentially a survey that hospitals complete. The survey goes to the CDC, and the CDC will collect this data to try to capture a snapshot about how hospitals are engaging in these evidence-based maternity care practices in support of breastfeeding. So a high score is good, a low score is not so good, and areas in which there are more Black people per capita will oftentimes rank lower on these scores, indicating that the breastfeeding support is just simply not there in these communities the way that breastfeeding support is there in other communities where there are fewer Black people. And this falls right along in line with what Dr. Davis was saying, that yes, there are fewer baby-friendly facilities in neighborhoods where more urban neighborhoods and with neighborhoods where there are higher Black populations. And so it is by far not a perfect solution in order to help support our communities, and especially our communities of color as far as breastfeeding goes. I should also mention, I didn't put it in this slide, but a lot of people are not aware that you do not have to have a lactation consultant on staff in order to be a baby-friendly hospital. This was by design by Baby Friendly in order to try to create a more inclusive environment, and to try to eliminate a barrier, because some hospitals just simply don't have lactation consultants on staff, period. But many of us do know that having a board certified lactation consultant on staff and making sure that they are able to access patients who need their care the most is critically important to the success of a breastfeeding patient. Even when you have educated nursing staff, educated physician staff, there really is nothing like having a good quality IBC on CLC on staff and having them at the appropriate ratios for the patients and the patient population in hospitals, but it still continues to not be required by Baby Friendly. So that should be noted as well. So breastfeeding is of course worthy of protection, like I was saying before, but we have lots of things in place that allow for vulnerable families and families of color to still be susceptible. Much of this was COVID induced. But I think many of us agree that, of course, even though we have not experienced a pandemic like this in our lifetimes, really should not have taken a pandemic to strip away so much of the support that was already in place. And we continue to struggle with this. And part of the reason why these supports were stripped away so easily is because they're not legally protected. Okay. It should not be legally permissible, for example, for a lactation consultant to be told that she now needs to help at the vaccination clinic because we need staff people. It should be that the culture is a lactation consultant is just as critical to the care of a breastfeeding mother as her OBGYN. Okay, but because that mindset isn't there, that's why these changes happen, and that's why they happen so easily, and that's why this is so dynamic. But then the long-term outcome is you now have a mother who has lost out on her ability to really receive the protection that breastfeeding could have provided her, like I showed in that first slide. And Baby Friendly stands as a strategy, but still much more is needed. There's a lot more research needed on how to make the Baby Friendly Hospital Initiative more friendly and provide more protection for families of color. And Baby Friendly is something that occurs at a cost. The hospital has to just decide on their own that they want to do it. If they choose on their own that they don't want to do it, then now suddenly there really isn't that much left in place to really truly enforce those breastfeeding protective practices. New York State has a Breastfeeding Mothers Bill of Rights. This is a great way to start. You can, one, educate the patient, make sure the patient knows, what am I supposed to get anyway? I know that my OB is supposed to take my baby out of me. That's all. But what else? Like, what else is there for me? And what else am I supposed to have? And what else do I have access to? This is one way. I'm not saying that we necessarily need to do this, but it absolutely is just one way to begin the process, for example. And so, these are just some ideas that hopefully I've helped all of us to really consider and think about, how we can expand our services, how we can expand our support throughout New Jersey. And thank you so much for your time. And I will pass this on to Jill, but I guess, Zakiya, I'll have you introduce her.
Excuse me. Thank you so much to all the presenters today. This is super informative. And so I'm not sure if you want me to pass it on to you, Jill, or if you want me to conclude.
Keep going.
Oh, okay. Yeah, so again, thank you all so much for joining today's conversation. It was such a treat to have local lactation experts and legislators gather to discuss the intersection of health and policy. In organizing today's meeting, we sought to educate, amplify voices of community organizations, highlight the importance of not only passing legislation, but enforcing bills, sharing resources and connecting with the legislative body to ultimately provide scaffolding support to birthing people. On behalf of Montclair State University, the Perinatal Health Equity Initiative, and the New Jersey Breastfeeding Coalition, we would like to thank our speakers, Assemblywoman Brittany Timberlake, Dr. Nastasia Davis, Dr. Rose St. Fleur, Ellen Mon, and Jill Watnick. We hope this is the beginning of an ongoing collaborative effort to ensure birthing people in New Jersey receive equitable lactation services and support.